Basics of elbow arthroscopy. To begin, the patient is placed in the lateral decubitus position with the operative extremity up and supported with an arm holder at 90 degrees. The arm holder should support the operative extremity proximally to allow intraoperative elbow flexion and to improve anterior compartment visualization. A beanbag positioner and safety belt are used to securely hold the patient in position. Bony prominences are supported with padding to prevent entrapment neuropathy. A sterile tourniquet is placed on the operative arm and inflated after exsanguination with an S-march. Anatomic landmarks are then mapped out to provide visual reference points of the medial epicondyle, the intramuscular septum, the olecranon, the lateral epicondyle, and the radial head. To distend the capsule and move neurovascular structures away from the joint when the trocar is introduced, the joint is insufflated through the lateral soft spot using approximately 25 to 30 mL of arthroscopy fluid. The ulnar nerve is stabilized externally while an incision is made for the superomedial viewing portal 3 cm proximal to the medial epicondyle and anterior to the intramuscular septum. Here, we can clearly visualize the capitellum and radial head. A proximal anterolateral portal is then created. This portal should be placed approximately 2 cm proximal to the lateral epicondyle and directly anterior to the humerus. Using this anterolateral portal, any synovitis noted in the anterior compartment should be debrided. Switching sticks from Arthrex's elbow arthroscopy kit are then used to facilitate the transfer of the camera from the medial to the lateral portal. It is important to directly visualize the anterior compartment from both sides to fully evaluate the joint space. Next, an incision is created in the lateral soft spot to establish a direct lateral portal. Viewing in this portal, a lateral accessory portal is made between the lateral epicondyle and the radial head. The soft tissue is debrided to allow clear visualization of the posterior compartment. The camera is then transferred from the direct lateral portal to the lateral accessory portal. Overall, the direct lateral portal is safe to work through as it is clear from neurovascular structures. Working in the soft spot portal, any lesions on the capitellum should be thoroughly evaluated. While evaluating the posterior compartment, flexion of the elbow may enhance visualization. Here, we identified a small osteochondritis dissecans lesion on the capitellum approximately 8 mm in size. This is treated with chondroplasty to create a stable rim. The base of the lesion is then debrided and chondral debris is removed. The base of the lesion can be lightly decorticated using a curette and a power pick used to create a microfracture in the lesion itself. Prior to withdrawing scope instrumentation, care should be taken to ensure the walls of the lesion are stable. A posterolateral portal is then established to permit visualization of the olecranon and olecranon fossa. A direct posterior working portal is also created at this point. Here, we can clean out any inflammatory synovium. The olecranon fossa is also debrided. After identifying the tip of the olecranon, it can be smoothed out to create a flush surface that has no impingement into the posterior aspect of the fossa during full extension. Portal sites are closed with 3-O-proline, sterile dressing is applied, and the patient is placed into a splint with a standard sling. The patient will begin early range of motion within 5 to 7 days. They will follow up in 10 to 14 days for suture removal, and return to all activities is anticipated at approximately 12 weeks.